Hello, everyone. Welcome. Hi, nice to meet you. My name is Fide Pineda, and we're just waiting for some participants to join.
Fide is also really excited about today, right, Fide?
Yes, very excited.
Me too. And the sun is shining. It's a perfect day.
Exactly. All right, so let's go ahead and get started. Thank you all for joining us today, and welcome to our third session of our Learning Collaborative on incorporating peer support into substance use disorder treatment. Okay, and then here we just have some brief information about the National Center for Health and Public Housing in case you haven't joined us for the first two sessions. The content of this learning collaborative is 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. The mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. So with us today, we have Dr. Kevin Lombardi. He is our Director of Research at the National Center for Health and Public Housing. Would you like to provide a brief introduction for those that haven't joined us before?
Hey guys, you know me, Dr. Kevin Lombardi. My training is internal medicine and epidemiology, specifically statistical epidemiology. My job is to look at the data and find new ways for us to support our communities. I was telling Fide, it's cold here, so I'm wearing my music and heart rhythm shirt, which I said is the kind of stuff that your mom gets you when you become a doctor because you're an easy gift. And here's my pitaya, my dragon fruit plant, and those are my fig trees. So that's what you need to know about me. Fide, can you tell them about yourself?
Yes, of course. Yeah, so I've been with the National Center for Health and Public Housing for 6 years now, and it's been a very rewarding experience because I've been able to grow here with my career. I'm currently pursuing my MPH in epidemiology as well, so hopefully I'll be graduating this summer, which I'm so excited about because it's been a rough journey. But I'm excited and
We're honestly tired of hearing her complain about it. I'm joking, Fide. Joke.
Yeah. Okay.
She's doing
So
great.
but yes, anyhow, I am happy to be here with you guys, and I am so happy to see that we have a good turnaround today. And we hope that you enjoy the information and that you find the information useful. Um, so this is just a few reminders that all participants are muted upon entry. Please make sure that you also engage in the chat, that you also raise your hand if you'd like your line to be unmuted. This meeting is also being recorded and the slides and the recording link will be sent to you all after today's session. So the session today is meant to be engaging, it's meant to be didactic, and we will be having a few exercises throughout the session to help with the interaction among the participants and also the speaker, Dr. Kevin Lombardi. So we do encourage you all to don't be shy. And if you have any questions, if you have any responses or any feedback to some of the information that we're going to be sharing today, please share it with us. And also there is no right or wrong answer for some of the questions that we will be having. And that is just one of the reminders I wanted to let you all know about. And now, without further ado, we'll pass it on to Dr. Kevin Lombardi.
Okay. I want to start by talking about a broad concept that's related to care for these incredible patients we provide our services to. Fide, I'm thinking about the things we've been teaching about recently and researching, and peer support is coming up a lot in a lot of different places. And I'm thinking here we're talking about substance use disorder, but it's increasingly being used for HIV patients, patients with the new HIV status, those with chronic HIV, infection, and chronic disease as well. So today we're going to see where those things overlap, how peer support can work in a multidisciplinary way. And the other thing is to talk about sort of our systemic understanding of these patients. And I like to think of public health as working in a systematic way, just like medicine does. And Fide, when you're in medical school, they teach you organ systems. Every 3 months. You go through a different organ system. For 3 months, we did, for example, the GI tract and liver, and through that time learning that and then engaging with patients, you start to see a really accurate picture of the liver in your mind. You think of the patients and you think of down to the molecular level, what happens in the liver, what it does. And what I'd like to say is the social realm, and that's the biological realm of what happens to patients. The social realm of the things that happen in their lives, and how their chronic disease, their SDOH, their level of isolation, their experience in the world, how it affects their experience is just as complex as those biological underpinnings. And by understanding our patients more, by listening to their stories and reflecting on our own humility, you can understand the details of, say, someone's social complaint with a level of accuracy as a physician understands a liver. And that's a very powerful tool when working with patients. So let's go forward. So the word of the day is humility, and I'll say why. Having worked with thousands of folks with substance use disorder, with every condition or every agent you can imagine, managing substance use disorder is a chronic disease as well. And it's a very challenging one. Not just how one's body reacts to abstinence from drugs, but when you're dealing with relapses, when you're dealing with the navigation of the healthcare system, it is extremely complex. It's like getting another job. And if you consider the comorbidities, well, we know that substance use disorder folks that inject drugs are much more likely to get HIV. These are very often comorbid conditions. And I'll say, we can say that roughly for the population as a whole. But if you're in one of those areas where individuals with that history tend to show up, like the emergency room, many of these folks are also dealing with significant social barriers that make them use those resources more. You're going to see these individuals very often, and you're going to need to know how to understand them and provide trauma-informed and kind healthcare. So let's keep going. Next slide, please. Yeah. So you guys know the system. We'll be going mostly through clinical cases today, but going through findings and recommendations as well. And Fide disclosed to you that she's a baby epidemiologist, and she's about to be an adult epidemiologist. So when I don't have folks to jump in, we're going to try to give her some questions and see how she can adapt to some of these. So get ready, Fide. And Jamoke, do we have you too?
She is in the line, but her audio is not working, so she's only going to be engaging in the chat.
Okay. Okay. Well, get your fingers ready, Jamoke. Okay. Well, let's keep going before I get myself in trouble here.
And by the way, Jamoke, she is our communications and research analyst. So just letting everybody know.
Joining us from vacation. Anyway, and next slide. We'll get started with the case. So today we're talking about Mr. Thompson, and Fide, I would like you to put a hat on. You are going to be, let's see, let's make you a public health educator, social work background, okay? Do we have any social workers in the crowd, including folks that manage or social work teams or social workers themselves? Hands. Anyone? Rick, do you mind unmuting and in wearing the social work hat and consulting on this patient?
Okay, let's see here.
We hear you.
Can
We
you
hear
hear
you.
me?
And what
Yeah,
I'll
we
say
hear
is,
you. Mm.
Rick and Fide, I'm not going to throw you to the lions like that, Rick. But Rick and Fide, have those hats on. We heard who Fide is. Rick, can you tell us who you serve and how you serve them, please? And thank you for joining.
Okay, well, this is my third day here, so I'm a service coordinator for a agency called CSI that works in conjunction with HUD. Before that, I used to work in social work in various functions for the last 20 years, from homeless to HIV to hospitals and such. Um, so my third day trying to learn all this stuff, and now understanding this case study. Let's see. I probably
Well,
look.
well, Rick,
Go ahead.
what I'll ask you is, I'm going to read the case and I'm going to throw you some questions when we
Okay.
come to the social realm. And I'll say we'll do that because we're modeling an interdisciplinary team. And when I'm working with colleagues, this is the way that we do it in the hospital and in the clinic. So I'll take the medical stuff. Fide is going to be our health educator, and you are social worker. So I'm
Okay.
just going to present everyone the case here. So Mr. Thompson, 57-year-old man who presents for a wellness exam at his health center. He has a past medical history of COPD and hypertension. The patient has a behavioral health history of major depressive disorder, generalized anxiety disorder, and substance use disorder. We don't see the substance, but remission 2019. Okay. Past medical records indicate Mr. Thompson has struggled significantly with headaches, mental health, and tobacco use since moving into his HUD-supported housing in 2022, with these becoming worse after his diagnosis with COPD in 2023. This gentleman is oxygen dependent and he struggles walking up the stairs or down the street without losing his breath. So, colleagues, we have a gentleman with a significant mental health history here who walks into the clinic. And I'll start with you, Rick. What's coming to your mind from a social work perspective when we see this patient?
Well, I just was wondering what his current supports are. How is he presenting regarding his ability to adapt to his environment at this point? Whether he may need immediate help, um, or if we could plan on resources. What is his wraparound resources that he has already? And at what stage uh, in the stages of, what is that called? Stages of change he's at regarding having help or getting assistance.
Mm-hmm. So you mentioned environment, which is a word that I thought was really appropriate to describe that, because look at these conditions he's dealing with. What I'm hearing from you is this is an intensively detailed and complex environment that this patient needs to live in. And that has a lot of medical implications, levels of stress and compliance. As a physician, I'm thinking and I'm worried about compliance with this patient because all of these medical conditions require compliance in order to have stability and for them to be the chronic diseases which we want them to be. And when folks are dealing with that, it's incredibly easy for them to miss something and for the whole picture to fall apart. Chronic disease after chronic disease. So, Fide, do you have any thoughts? What's popping up for you for this patient? What's coming to mind?
Yeah, I think for me also it's the fact that he is dependent on oxygen and that he struggles to walking up the stairs or down the street without losing his breath. Like that is a big red flag in terms of how he would even try to look out for himself,
Mm-hmm.
and follow up with his own treatment on his own if he is having any kind of treatment at this time. And then we also did receive a comment here, so sorry, that says, I bet his mental health is on the back burner due to his physical health. So yes,
Okay,
also take
okay, finish,
into
and then I want you to pause that one. But you were saying, was that your statement? Did you have anything
yeah.
else?
No, that was one of my statements. I don't know if we have any other participants that would like to chime
No,
in.
I want to touch on that for a moment, because the oxygen therapy is a big deal. I did my training in an area that had a cotton mill, and the smoking rate was over 50% in Danville, Virginia. And we had a lot of patients with COPD. And what I can tell you is a chronic diagnosis, a serious life-changing diagnosis like COPD, those folks are at higher risk for substance use disorder. And it is not uncommon to see them come into the emergency room with those comorbidities on their records. And this paints to the complexity of those conditions. Yes, but could you refer to the comment? Because if you could ask our participant to join, because and tell do you think, Fide? Do you think?
Of course, thank you. Yeah, we did get feedback from Jay. Welcome, Jay. So happy to see you again. He says, I feel like he needs stabilization first. Nicotine is a substance. Is he wanting to or willing to cut down or quit?
Jake, could you give it to us from the horse's mouth?
So, I mean, I look at this, and we can look at this as a bundle of disorders or a bundle of comorbidities and say that, Mr. Thompson has this, and this going on. And all of these are really important factors that are going to play into his overall well-being. But the most urgent thing that I see is that he's still using nicotine. Don't get me wrong. I was a smoker for 25 years. Like, I still use an incense oil inhaler because I'm like, it's only been a year and a half since I quit smoking. I understand how powerful that is, but he is on oxygen. Not only is it highly explosive, but we want to prevent further damage from happening to his lungs. Unfortunately, he's probably not going to regain any of his mobility. So we need to pair him with someone that has experience in working with chronic health conditions and learning how to adapt to what his reality is. Really unfortunate way to phrase that, but it's what I see as being the case. His lungs aren't going to get any better at this point. So let's see what we can do to stop damaging them. And then we can work on, some of the things that are going to go along with that. He has a health history of MDD and GAD, but are those present? Are those managed? Are those sustained? Right? Like, how is that going? His SUD is in remission, but that doesn't mean that he wouldn't benefit from working with someone that maybe specializes in smoking cessation, if he's willing to do that. Ultimately, he is able to self-determine, no matter what any of us think or want for this individual.
Yeah, 100%. And that last statement is a really important one. And I'll say, let me give you a counterfactual, though. If I'm this patient's primary care physician, and this is the truth, I've given up with that tobacco cessation. I've been mentioning it for years, and he won't budge. It's written in the records, actually, that he won't budge. If anyone reads my stuff, they can see for the last 2 years I've asked him for it, and for the last 2 years I've documented it. And what you say emphasizes the importance of the trust with the peer support system, because are they going to listen to me, or are they going to listen to the peer support provider? And the answer is pretty obvious there. And it speaks to the reality of what physicians are really doing in the room. Is we've got 15 minutes. This patient has COPD and has all of these conditions. Trust and believe the smoking is not a priority in that exam room. Trust and believe. Next slide, please.
What would have been the priority in that exam room?
What's that?
I said, what would have been the priority?
Well, I'll tell you what, it's going, whoever walks in the room is going to give you a different priority. And I'll tell you, with these difficult patients, often the arguing between the physicians is what the priority is. But for me, if he's presenting with the COPD, it's his breathing and how he's there, stabilizing him and getting on his oxygen at his standard level. Social work will take care of the smoking. I click a box. But if I'm seeing him in the clinic or in the emergency room, I do not have time to address that more than just a question or a statement. And that's why these services, like, if y'all don't do it, it doesn't happen. It does not have the time. Even when you have residents, medical students available, sometimes you can increase that, but these patients aren't having the conversations the way they should. And from my analysis of national data, I can tell you it's not just my anecdotal or practice opinion. It's happening. So, Fide, you know how to read vitals. Tell us about this patient.
Okay, I'm gonna try. The patient undergoes a standard.
We need.
The patient undergoes a standard intake, including vitals and an SDOH screener. The results are as follows: had a blood pressure of 178/98, a heart rate of 92, and a respiratory rate of 18. A review of Mr. Thompson medical records also indicates the following: that the vitals in 2018, he had a blood pressure 138/98, a heart rate of 60, and a respiratory rate of 26. He also had a HbA1c level of 7.0, and the drug screen said and negative. And his prescribed medications include chlorothiazide and citalopram, Celexa. So basically,
Yeah, go.
oh, what I was just gonna say that based on like the most recent intake, which is the one on the top, it shows that he has very high blood pressure. So I'd be curious to know how that would be managed for him as a patient.
Well, you know what I love about vitals is they tell a story, right? So I'm looking here at a narrative and I'm trying to decide what this narrative is. So I see you're 100% right. This patient is hypertensive to the point where he is almost at a hypertensive urgency, actually, which would mean if I saw this patient in the clinic and he was 10 systolic higher, I would send him to the ER. I'm seeing his heart rate, high, but not surprising considering the blood pressure. Respiration's 18. Okay. I see patients like this all the time, though. This is for the gentleman that was just described, this is not a surprise to me, right? It's what happened in the past that puts it in context. I'm seeing 138/98, 60, and 26. So, one, his respiration rate is really high, but in the context of the COPD, not surprising. But look how well managed his blood pressure was. That wasn't, it was still hypertensive, but I mean, way better than what we're dealing with now. And I see his medications. So, can anyone think of is anything coming to someone's mind about why this blood pressure might be going higher here? I won't spend too much time on this, but it's something, it's interesting.
Well, I noticed that like when some people come in, their situation with their housing, for example, may have changed, so they don't have a place to be, they're homeless. So compliance is a big issue, and trying to get the medications at a certain scheduled, way is almost impossible. So these are the things that are mentioned sometimes when I've talked to some clients regarding these changes that go on.
Yeah. And you know what, Rick, when I'm in the clinic, I see the other side of that, which is oftentimes these patients come in and they're taking a half dose of medication because they can't get a prescription or they just haven't had it. Sometimes they'll come to the ER for a refill, even though that is not the use of that system. A lot of our unhoused individuals. And what I've noticed through my own practice is that in those settings, individuals don't necessarily go around screaming, "I'm unhoused at the moment." It's not something that's often told when you have that 15 minutes with the patient. So when we see a blood pressure like that, it asks us about what might be going on. And I'm seeing those stressors and I'm seeing the medication adherence. Compliance is the first thing that's coming to mind for me, 100%.
The other thing that I noticed that every year when it comes to this Medicare re-enrollment period, they're changing over insurances, and sometimes they fall through the cracks. So they're not able to get the medications necessary for getting that. And so they're going through all these hoops. And I find that I have to get them scholarships so that they could get the medications so that they could be in compliance.
You know, and I'm gasping a little bit here because I'm thinking of the time of year when we get a lot of admissions for that sort of thing, and I think you're 100% right. I never thought of that, but that is that's indications that's a huge systemic effect on our patients. Next slide, Fide. Before I talk for the day about blood pressure, it's a narrative. I promise, it's a narrative. Fide, STOH screener. Why do we do these?
It just gives a better overview of what the patient is going through. What could be some of the underlying issues also of like the current state, his current health state.
It triggers something too. When these are done in your medical record, when patients are being or are say coming in for an appointment, that's where we recommend giving the STOH screens. This is a powerful tool to ensure social referral. It can be either, is it a case manager, a physician, advanced practitioner, nurse who's doing referral? It doesn't really matter. If this is being done by the patient in the beginning and following them, the opportunities for referral are much greater. And STOH questionnaires tell us where to ask the more structured questions. So take a look here, Fide. What are the things that are the red flags about this patient that pop up for you based on this first page of the questionnaire?
Yeah, so the main thing here is that the patient does have trouble finding or paying for a ride. So he has transportation issues.
Can you do the next page too, please?
Yep. Also, the patient also is unemployed, doesn't have a regular income. He also needs help finding a better job. He also is concerned about someone that may be using drugs or alcohol at their home, and also feels unsafe.
Okay. Well, we got some questions to ask. Rick, what's coming to the forefront of your mind when you see this questionnaire?
Well, I guess the thing that sort of is pressing to me is when he says he's unsafe. I don't know what that is looking, what does that mean? I would explore that first to see where he's at in that regard. The other issues regarding unemployment and how the barriers are keeping him from being unemployed, tying him to resources like vocational rehab or other resources that could be able to help bolster his ability to be more successful. And what was the other one where it said
Transportation.
alcohol? Transportation. Oh, trying to find if there's some insurances that supply transportation, what his insurance may have, or to have some type of community resource that might be able to assist him if he's having some problems with transportation.
But you did mention number 9 there. So number 9, there is something on alcohol. And
yes. And that would his concern about someone with home using drugs or alcohol, probably explore that as well. How it's affecting him. Is it kind of encouraging him or, for a relapse or using or whatever, what could be done to address that if he feels that's a concern?
Mm. So when I see patients like this, I get really scared. Because when you have someone who is dealing with this chronic condition, substance use disorder, and let's say it's opioid use disorder, and there is a relative, someone at home who starts using it again, the story from there is often not a good story. And we know from the data that folks that are exposed to these substances when they've been abstinent are at much higher risk of relapse. And what I'll say is when you see that story unfold in front of you, it's a very sad one, because sometimes years of abstinence has built up to this point. So that's something that needs to be investigated. And the safety is the first thing that comes to my mind as well. What is unsafe? Unsafe means a lot of things. It means a lot of things. So this patient, that needs to be addressed very quickly, and we need to have an understanding about what this means to the patient. 100%.
One of the things that come into my mind is maybe having a safety plan and harm reduction that might be used in cases if he, decides to use or whatever. But trying to find a safety plan where he could be able to follow through, hopefully connected with someone that could be I don't know, a sponsor if he's going to a support group or something like that, just in case something may occur.
And I'll strongly agree with you on that, and to say that this is a patient who needs a relapse plan if they don't have one, and peer support is a great way to get that. It's one of the best studied interventions of peer support is when folks work together to make mentors work with folks to make relapse plans, and that saves lives. Next slide, please. And Fide knows this, but we use the Italian table method here. Just start talking if you want to add anything, folks. So let's look at Mr. Thompson here. So he's treated by his provider. On physical examination, we see, okay, he has a barrel chest posturing, struggling to breathe when he speaks, even while on oxygen, unable to walk to the door of the exam room without his oxygen. While on oxygen, he's able to walk down the hall without losing his breath, making down the hall. And his spirometry puts him at a moderate to severe COPD. The guy's still smoking, by the way. Okay, so this is to get just across how complex this patient's condition is. This COPD is difficult. He is going to struggle to get out of the house. He is going to struggle to go to the grocery store, to even do things within his own house or like direct social setting. There's significant safety concerns that they might have at home as well, but that's how complex this condition is for this patient. Next slide, please. Okay, let's open it up, folks. Fide, could you do your thing?
Yes, of course. All right. So with this first question, how does Mr. Thompson's chronic disease complicate his substance use disorder? And the second question, is he still a candidate for peer support? We're gonna allow just maybe 2 minutes, Kevin, for people to start thinking about their answer, or do you want to just do it now?
Oh, let's just go right into it. Let's do hands
Okay.
or chat, just whatever
Okay.
comes first. Italian table method.
So if you have any responses to any of these questions, just unmute your line and we'd like to hear your response.
So first of all, Fide, is he still a candidate?
I'm sorry, can you repeat that? Is he still a candidate for peer support? Yes, absolutely.
Is he still a candidate? Is, peer support for substance use disorder, is that still a priority for this patient? We're talking about COPD. Is that still a priority? Yes, absolutely. Yes. But is it often not deprioritized? Yes. but it still needs to be a priority for this patient because these conditions are intertwined. I'd like you to think of chronic disease and social determinants of health. It's kind of like weaving together like a rope, and that rope is the patient. And trust and believe, if you want to take one of those threads out, it makes that rope weaker. So yes, he's absolutely a candidate for peer support. And when we think about peer support with this patient, it emphasizes the importance of knowing which peer support stuff is available in your network, because I can think of really whatever this patient, what is available. Is it chronic disease peer support, substance use disorder peer support? Are there individuals in those networks that have maybe had multiple of these, that maybe in one group or another? That's where your case managers and your social workers can really help you to divert someone to the right peer support mentor. But yes, he absolutely is. But let's talk about his chronic disease again. So remember, this is the patient who's in his late 50s. He's got COPD. We've seen that his COPD is bad. How is this complicating his SUD? Other than it's just difficult. So if let's start with social isolation. Does social isolation come to you as an issue for this patient, Fide?
Yes.
100%. And what makes you think this patient is perhaps more likely to experience social isolation, just based on what we've read so far?
I think, well, I guess again, this is all my speculation.
Please
But it could
speculate.
be, yeah, it could be because I think this patient has maybe feels a little bit of stigma related to his issues. You know, maybe does not feel comfortable sharing that he has substance use disorder with just anyone. He may feel isolated also because he's experiencing all of these social barriers. We are having some people.
Well, go back a page and comment on that and how that's related to this social isolation.
This one?
Yeah. So when you consider this specifically, does that
Yeah.
add to what you're saying? Because you're 100% right. You're 100% right.
Yes, like Mr. Thompson's not to exhibit a barrel chest and posturing while sitting. He struggles to breathe as he speaks, even while on oxygen. So even just that alone, him struggling with speaking, being able to communicate things to other people, even at a clinic, maybe, all of that can make him feel insecure in some way. Yeah,
And
we did have some feedback in the chat. Would you like for me to unmute the line?
in a moment, I just want to comment on what you said first. And it 100%. And remember, it's like a rope, and you just got two major parts of it there. One, the patient's substance use disorder. There are issues of stigma that may be there for that patient. Also, this gentleman is struggling to walk around his house. He's not going to get out. He's not going to get his friends. He's not going to access his family. He's not going to access his social support network. When the social support network is gone, it makes all of these conditions a lot more difficult to manage. And when I mean a lot, I mean a lot. Each of these conditions is kind of like having a part-time job. If he's got COPD, he's going to have inhalers multiple times during the day for a moderate or severe goal. Absolutely. So that needs to be they need to get that at the pharmacy or from their mailbox. He might not be able to walk to his mailbox to get this. Substance use disorder issues, potentially someone who's using at the home. And remember, they talked about safety too. The patient was feeling unsafe. And what I can say is when I consider this patient's story, I can think of a handful of reasons why they are feeling unsafe. Even if we're taking the domestic violence and the elder abuse out of the picture, just this patient's environment might be making them feel unsafe. So following those questions in the SDRH questionnaire is a great super highway to the problems. And I'll ask you to go 2 slides forward, please. No, sorry, Fide, you said you had something. I'm sorry.
Yeah,
participant.
Yes, absolutely. I would like to see if April would be willing to chime in. I do. Hi, April, how are you?
I'm good. I'm good.
April, could you tell us, could you remind us who you serve, how you serve them?
I work at a federally qualified health center. I'm the director of behavioral health, and we're actually we wrote a grant and received it, and we are implementing peer support into our program, which I'm extremely excited about. So,
Me
being
too. That's amazing.
Yeah.
I know. So we have medical and behavioral health both here at our facility, and this patient is a typical patient that we would see here at our facility. It's easy for these patients to get just overwhelmed, overloaded, and just downtrodden. And I think it's like you said, when they come into the ER or wherever they are, the first thing is we got to get their respirations up, because if they're not breathing, they're not living. So once we get that figured out and improved, they're sent on their way. And it's not any fault, but just the way the medical system is. And a lot of time their mental health and substance abuse history is, we want to address those things, but it's hard. So that's what we're here for. So we know that mental health and physical health go hand in hand. And if we can just make sure that we're addressing all of those things. So what they do on the medical side is they put a referral in for us, and we follow up with the patient. So, we can't make the patients do what we'd like, but we sure can reach out and try.
Thank you so much for your service to your community. I love that you guys are expanding what you're doing, and that's just so encouraging. And I can see you put a lot of, just for how you describe your patients, you have a lot of humility in your work as well. So good for you. And that speaks for the crowd as well. These patients teach us so much. Yeah, no, 100% and absolutely. Thank you, April. And what I'll say is the complexity of this patient's condition is overwhelming, and we can't expect them to have success if they don't have specific and targeted support. 100%. Two forward, please, Fide. Okay. We have some details here. So we had an SDOH screener and we looked at it. So patient worked as a welder until 3 months ago when he was laid off. He has 2 months of unemployment available. Okay. He's behind on his utilities and his truck is unreliable. Uses Uber for transportation. He's having frequent panic attacks. Okay. He lives with a wife who was also a past opioid user, remission in 2019, around the same time as him. He lives in a well-insulated basement apartment built in 1968. Okay. Okay, he gets a 20% disability from the U.S. Army every month. And here we go. Fide, why don't you read that last one for me?
And Mr. Thompson has been taking a half dose of his prescription medications because he can no longer afford the medication.
Mm-hmm. And sometimes it takes that long to figure that out. What we should have done is be able to catch that with the patient's vitals. But now we know. So you have all these new social details here. Rick, are you able to give us your opinion on this patient now that we have some new information?
Yeah, it gives a little bit of information so that I could identify resources and strategies to see if that could be beneficial for him, if he decides, being that he's a veteran. There may be things where he could be able to get resources through there for support. And also with the medications, I think they have programs that could be able to help him with either scholarships or based on finances if he's not able to afford them. Let's see what else. I believe they have resources for if he's married to his wife, they have resources that could be able to provide him care with you know, any services for, you know, sobriety or anything like that. And I believe they do have things for their wives as well, to provide resources through TRICARE and such. But what else was there?
Yeah. No, you nailed it, Rick. And the thing that I've worked with veterans for years. I trained. I did 3 rotations in medical school and residency in veterans hospitals. And what I still did, I can say, is there's some great things about the system. Some of the best hospitalists I've ever worked with are in veterans hospitals. But there are some frustrations that veterans have with navigating the system. It has its own complexities, if you're considering this is a patient with COPD that can't even get out of the house, sometimes folks like this might not have their TRICARE. They might not have things. Well, we know he's getting a pension, so he's at least enrolled somewhere. But to think of the resources that may be available through the Veterans Administration, they could potentially be life-changing for this patient. And I don't know those details, but when I'm in an appropriate interdisciplinary meeting and I hear those details, I see this is going to be much easier for this patient to be compliant. And for that is primary for my medical management. So thank you for the opinion. Fide, anything come to your mind? Anything else that Rick or I haven't mentioned? You get the final throw at this.
At this moment, I don't have anything else. I think you guys have mentioned they're pretty much a lot of very important aspects from this. Yeah.
I'll throw one more in, and it's the frequent quote unquote panic attacks. And he has MDD and he has GAD and he's having breathing issues. What I'll say is, for patients with COPD, they have to sleep with their heads elevated. Oftentimes they'll have sleep apnea or they'll have a breathing. Sometimes they have a BiPAP they need to use, depending on the severity of their condition. If they have MDD and GAD, they are much more likely to have panic attacks because it's just all of those stressors at once, especially at night. And if they're smoking, often folks that smoke heavily have phlegm production, sputum production throughout the night. So consider this patient. He has MDD, GAD, has a history of panic attacks in the past before he had all of these medical issues. Now he has a breathing issue and an addiction issue that makes him feel like he's drowning in his own lungs at night. They wake up and they get very scared, these patients. And when you consider the reality of how it is living with those conditions, it's not a surprise. If I put you through this for a couple of days, you'd be having panic attacks too. And I say that because understanding how complex these patients' lives are, just something small like sleeping can help you understand some of the challenges with compliance and so forth. Next slide, please. Okay, so we've talked about this. Next slide. Okay, so and we're falling a little behind, so let's see if I'll pick out the important things here for us, Fide. So one, we know so in the past he worked as a contractor. He started using opioids during periods of employment. Not an uncommon story. When we consider contractors, welders, folks of that sort, long periods of unemployment are not unusual. Sometimes they'll have a job that goes for months and they're working, every day of the week, to say in the winter, there's nothing. And I know for a lot of contractors, for example, where I'm from in the Boston area, they don't work in December and January because you can't dig in the ground. Folks are on temporary unemployment. And if they have a substance use disorder, they may have more time to be exposed to those risks of relapse. So these are things to keep in mind. But that sort of is the story of how Mr. Thompson got to that. and was ensnared by that addiction. He lives in a basement apartment. He's worried that his wife's using again. Small apartment with wife who he's concerned is using again. He's unable to work because of his disability. We know that. And he's reliant on his Army disability alone. He's too young for Social Security. In the social isolation. He's not attending social events and visiting family or friends. If this guy's a veteran, he may have had a, say, weekly foray to the VA hall. He may have a veterans group that he's no longer able to see. This gentleman's entire social network has been severed by his condition because he's unable to leave the house. So consider that isolation and consider if someone has a history of substance use disorder, how that might affect their likelihood of retaking that and of relapse, and especially when there's someone at home that might be relapsing too. This emphasizes that the social support with this patient is urgent. It's as urgent as treating his breathing issues. It's urgent and forefront. Next slide, please. And I say that as a partial reminder to myself because in the clinical realm, when we have patients with medical issues, we often tend to hyperfocus. Where I'd recommend doing the STOH screeners, I throw this everywhere. At the intake of primary care appointments and at the beginning of follow-up engagement, my recommendation is do one in both circumstances. Patients often give different answers, and you should have a baseline for comparison. Next slide, please. Okay, new case. So, 35-year-old woman in medication, these are short cases. A 35-year-old woman in medication-assisted treatment for opioid use disorder has been attending regular clinic visits, but recently started missing appointments. During a routine check-in, her CHW specialist noticed changes in her behavior and gently engages her in a conversation, creating a non-judgmental space for disclosure. Good job, CHW. Next slide, please. The patient admits to relapsing when they talk to the CHW, but expresses fear of disappointing her healthcare team and losing access to treatment. That's why the doctor didn't hear about this. When the CHW specialist encouragement, she discusses her struggles, and we hear more about that. Next slide. Here are the details. The patient has lost stable housing, leading to increased stress and instability. Patient has also recently lost a job, creating financial insecurity and difficulty affording basic needs. Conflict with family members and reduction in her support system. The patient has chronic pain issues, increasing temptation to misuse opioids. Social stigma and fear of judgment, and a transportation barrier. Now, when you consider all of these things, Fide, and you consider that this patient has recently relapsed, do you see how these social determinants may have made that more likely that the patient would relapse?
Yes, absolutely.
Can you pick one of them and tell them the one that pops up the most in your mind and what process? What comes to mind?
I think all of them pop up to my mind, but the main one is the loss of stable housing, which that just automatically, I think, increases your stress and instability emotionally, physically, at so many levels, you know?
100%. And if we're talking about a patient who is now unhoused, who previously was not, it's very difficult to avoid. Depending on where one is unhoused and how they are unhoused, they may be put in circumstances where they're exposed to the substance which they are trying not to relapse on. And it's very difficult to control one's environment or to stay away from those when you don't have your own home and your own space to control. It's a common route to relapse, and when you see that housing insecurity, it is the primary red flag that should pop up in your mind for this patient, especially if you work at the National Center for Public Housing. Yes. Next slide, please. So, Fide, I'll say the question and it's yours if we have no hands. Could you read the question and do your thing? I think everyone's tired of hearing from me.
Of course, yeah. Why is this patient appropriate for a referral to peer support services? And what specific supports could peer support provide? Please let us know in the chat. Or I can also try to pick out some names and hopefully you'll be able to participate. All right, let's see. Ana Martinez, are you available? Lisbeth Rios?
Take it, Fide.
Yeah. All right. So why is this patient appropriate for referral to peer support services? Yes, I think, well, one, it would also help this patient manage the relapse if she is, referred to like the right services for this. And then what specific supports could peer support provide? Access to health education, maybe some new medication that she may need to help her manage her substance use
Navigation,
disorder. Yes.
100%.
Yeah, those are some of the things that come to my mind. I don't know if Rick, would you like to chime in? And also,
Yeah, I think that that's one of the things I kind of typed up a little bit is that it's not the feeling that that person's entirely alone, but feeling that, there's someone to provide support, to give him that motivation and to be a model for him so that, he could be able or she could be able to try to understand and kind of use that information for that person to make positive steps for his care or her care.
100%. And I so appreciate what the both of you just said, because peer support is going to provide, peer support is peer support, but it's many different components. And when I think of a patient like this, something from my perspective that's going to be very valuable is making a relapse plan. The second thing that I'm going to find really valuable is having a mentor to help them navigate the system, the MAT providers, and so forth. The other thing is if this patient is experiencing relapse, education from a peer is going to help them significantly. What parts of and I think of the SDOH and housing issues too. This patient is going to be, is unhoused, and having a peer when you're dealing with a period of intense social isolation is going to be a lifeline for this patient socially. And it's potentially a road to those other resources as well. Often peers, especially peers who have experienced homelessness themselves, can provide very life-saving connection to resources because they've survived it, they've gotten through it, and the amount of expertise it takes to navigate out of homelessness is pretty incredible. So with that, I'll say thank you all so much thanks for joining us, everyone. Thank you all so much for your service to our patients and our communities. And I hope you had a great time. And I hope you and your patients have a great week, and colleagues as well. Fide, take it.
Thank you. Thank you, Kevin. And thank you to all the other participants that engaged with us today. I just wanted to remind everyone to please complete our post-evaluation survey, which will pop up on your screen right after the session. Also, we have our last session next week on Monday at 2 p.m. So we are looking forward to see you all during our last session where we're going to be wrapping up everything that we've learned. And then also you can find and access our latest publications, the webinars, and the recordings to this learning collaborative on our website at nchph.org. Thank you so much, and we look forward to hearing from you all.